This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you. I have no conflicts of interest to advise you of. The nuns keep saying to me, "Shane, your reward will be great in heaven," and I keep saying I'm going to get there much faster than I expected. Rapid response systems have, I suspect, in the main been introduced without writing a business case. Now, in the early days, this probably resulted in turf wars and slow adoption, which could have been avoided by better marketing. But the consequences today are underfunding, neglect of essential elements, and a poor appreciation of financial and clinical costs. So, there are a number of different models, but they all have certain things in common. They must address the value that's going to be created, who is really being served, available resources, and competition, funding and scope. It's helpful to have a business model canvas. Now, this is a technique used in businesses to write business plans where you have a semi-graphical format to put all of the concepts on one page. Now, regarding rapid response systems, key partners include the ward-based clinicians, other critical care units, specialties like anaesthesia, administration, and of course, the patient and his or her family. This is an acknowledgement of Ryan's rule. What will the attending team actually do? Will they assess and triage, or undertake more complex and prolonged resuscitation? What are the implications? Relationships are important to capture, especially with strategic customers such as VMOs. Are we going to provide a comprehensive service to all patients, or will we fragment the service to provide specialised responses according to case mix, like obstetrics? Capturing all the costs, including education and data collection, is essential. What expertise and clinical resources do we already have at our disposal? And how will it be funded? Fee-for-service, block funding under ABF, or a levy imposed on clinical units? Today, we aren't in the position of having to sell the rapid response system to hospital executives. They've already bought the concept, and compliance with National Standard 9 makes rapid response systems part of business as usual. Introducing any new service or product has a characteristic diffusion curve. Now, today we've got a much more mature MET system. We are way over to the right of that curve. And what that really means is that stakeholders want solutions and convenience. Clinicians, administrators and patients want a mature service that works seamlessly, in other words, free from bugs. So when approaching this task recently, my starting point was a gap analysis between the reality of what we had and compliance with the national standards and best practice, as was described in the literature. Now, I suspect many of these issues that I identified would be germane to rapid response systems throughout Australia and New Zealand. Hands up who thinks many of those things are problems for your institution. A fair number of you. So, in defining what we were going to do about it, clearly if you wanted something that was going to be better, we needed three legs to support the system. Otherwise it was going to fall over. And in particular, the thing that was missing for us locally was the governance limb. We had already introduced a modified version of the QADS chart, a weighted track and trigger system for the afferent limb. We had a somewhat bewildering efferent response, which was complex with lots of built-in redundancy. Really, it was based on the principle of how many people does it take to change a light bulb in the hope that one of them has fingers. And it clearly needed streamlining. Of course, one of the fundamental questions is who is the team? And we're talking about the deteriorating patient here. We're not just talking about a MET team or a MET system. Is it the MET team? Is it the ICU? What about ward call? Other on-call registrars from subspecialties? Is it the medical doctors who have that general experience that not many people seem to have anymore? Where do the nurses fit into this system? Do theatres and indeed theatre staff like the anaesthetists play a role? And what about the specialists and VMOs? The choice is between many hands and a few. The implications of this decision are profound. We could have an approach to patient safety that makes it everyone's responsibility and relatively few calls, or we could delegate the sick and inconvenient to be cared for by the ICU doctors. Now, closing the gate after the horse has bolted will not improve mortality. I'm quite alarmed by the concept that perhaps 25% of patients who receive a MET call are destined to die within 30 days. Now, many of them may have been unrecognised palliative patients and have not had an NFR order placed, but it still leaves it open that there's people that we are leaving on the wards who will do poorly. A graded early response, which has as its centrepiece the urgent clinical review by the treating VMO or clinical team, is essential to improve outcomes. So this is an important point because we're not offering a MET team that comes with absolution from responsibility for every other doctor and nurse in the hospital. It's important when writing a business case that you don't create a Frankenstein that then turns upon the inventor. And I wonder, hearing the rates of MET calls in some institutions, whether that might be what's happening. Perhaps the most neglected area in planning a rapid response system is a detailed financial plan. Now, this is not a money-making service, but it does cost. The purpose of this slide is to overwhelm you, but the message is that various financial inputs can be considered by the model. My suggestion is be inclusive. Underselling the cost will guarantee that you get paid what you have asked for, almost. Businesses have a life cycle that includes early investment and sunk costs before eventually maturing and paying a dividend. Now, I believe a problem with how we've implemented rapid response systems is that we haven't made the upfront investment in training and governance. Neither have we acknowledged the ongoing costs of operation over time. You heard from Daryl Jones that from 2010 data and then more recently 2014 that perhaps 2/3 of our systems have no additional funding. A sensitivity analysis allows prediction of costs by varying basic assumptions and the elements of the model from simple to more sophisticated. Money has a time value, and when you're considering a service which is not going to be around just 1 year, you need to take into account the 5-year view. And the more inclusive you can be at this stage, the less likely you're going to be confronted by hidden costs in the fullness of time. Of course, administrators in Australia like to believe in the concept of the magic pudding. This is the gift that keeps on giving for free, which of course is the MET system. However, even the most heroically optimistic assumptions must include modest growth of the service over time and inflation indexed to the CPI. A lean model perhaps has no funded governance or training positions and may be purely medical in composition. Accordingly, a forecast can then be generated for a 5-year period. But even this anaemic model with a very low rate of MET calls still costs something, and this would be a gross underestimate. I probably should have named this slide realistic rather than pessimistic. Healthcare historically has increased at an inflation rate of 6% per annum. Nothing succeeds like success, and the inherent demand of rapid response systems and their acceptance of their role today means that there's going to be a much higher rate in the growth of calls. A multidisciplinary team is probably the best model, it would seem, and I don't think that it's an ambit claim to suggest that a funded medical director, at least part-time, and a nurse educator QA officer role should underpin the governance of the system. Nevertheless, the costs of a fully fledged model over 5 years can be quite confronting. And again, this is a fairly modest model compared to some that we know of from around the country in C24 hospitals. Now, I contend that we shouldn't shy away from presenting this reality to hospital administrators. Rather, we should make them aware of the real costs and the real deficiencies of existing services. I believe this is a necessary conversation based on data that is essential to crystallise their thinking. Otherwise, the magic pudding theory of rapid response systems will be embraced unchallenged. Where will the money come from, I hear you say? Well, in my institution, it's still a case of Peter robbing Paul. I don't know that we're at the point where we can bank cost savings from improved patient outcome. This remains an area for further research. Perhaps we can make a case for improved staff retention rates, reduced parent unit overtime, more efficient use of our ICUs and avoidance of litigation. But we must acknowledge the propensity for cost shifting and possibly an increase in high dependency use. If you consider that previous slide with an estimated cost of $1.5 million for a fully fledged system over 5 years, based on a benchmark of 50,000 US per quality adjusted life years saved, and that's a benchmark that's used internationally for evaluating cost effectiveness of therapies. If the service rescues just 30 people and extends their quality of life by 1 year, then it will be acceptable value. In the final analysis, it may be, though, that safety and quality cannot readily be reduced to a dollar value. In the dismal discipline of economics, there's a sweet point at which a service or a production line is most effective. I think the frequency of MET calls needs to be defined for each institution relative to the size and resources. Too few calls may be ineffective, as we can obviously understand, but endless growth may result in cost blowouts and degradation of overall clinical performance. At my institution, I keep asking the question, why would it be a good thing to have more medical emergencies? Now, acronyms such as MET can be dangerous in the way they obscure meaning. It's said that the road to hell is paved with good intentions. Just because rapid response systems enjoy strong face validity and seem like a good idea doesn't mean that they cannot do harm. Any business plan must include a treatment of risk. Otherwise, you'll go broke or worse. Indemnity for the MET team, particularly in the private sector, is an unclear issue. Without a strong governance framework, how can there be accountability? Most of these risks, however, do attract costs and can have a dollar value set beside them in a comprehensive plan. I believe that these systems should be corporately owned. They need strong, identifiable leadership. Locally, our system was an orphan and is still struggling for adoption by a parent. It's perhaps an example of a universally applauded great idea that no one wants to accept responsibility for. It is imperative in the design phase that the followership not be given an opt-out, and I would suggest the followership is the entire hospital, the entire organisation. At the completion of any business plan, a crucial step will be pitching the proposal to the administration for the first time. In my limited experience, hospital executives are not angel investors looking to donate funds to an enthusiastic entrepreneur with a great idea. Be careful in offering a compromise model, because that's probably what will be seized upon as a cheaper option. Thereafter, the journey toward better outcomes for deteriorating patients will be fixed on a lesser path. Having gone through this exercise in re-engineering our rapid response system, I've learnt that it's a journey and the plan is just a starting point. Of course, it has to be implemented. That's the hard bit. But all the same, the better the plan, the better the starting point. Thank you.